So, grüß Gott, meine Damen und Herren. And to Gert, danke vielmals. And to Doug, thank you very much. And to Iveta, dziękuję. And to Trish, thank you very much indeed for the introduction. An effort. Before starting on the talk, I wanted to mention something. If you go into the Munster from the west door, and you go more or less immediately to the right, you'll see a photograph, and you'll realize how lucky we are to be in this building. Just before Christmas in 1944, the Royal Air Force basically flattened everything in the Munsterplatz, with very few exceptions. If you have a look at it, you'll see that this is one of the few buildings with the roof still on. So we're very fortunate to be here. It reminded me very much of my recent visits to Gaza, where I was 2 weeks ago, in fact. And it's a sort of indiscriminate, by the RAF and by the Israeli Air Force, a sort of indiscriminate terrorist bombing of civilian populations. And it's just a reminder here of what a dreadful thing war is and the munitions which are used. Now, to the talk. If you go into the Munsterplatz and you ask someone, do you think that researchers, before embarking on new research, should find out what is known already from previous research? Can you imagine anyone saying no? And indeed, can you imagine a lot of people saying, you can't be serious? Surely that happens. Well, as I intend to show you, it doesn't happen. And not only that, it's not even accepted by some very powerful people as important. I was asked to give I was very grateful and proud to be asked to give the first Equator lecture some time ago. And when I asked Iveta what you expected some old person like me to come back and talk on, because I've been whittering on about the same problems for 30 years now. Hasn't made a blind bit of difference, as some data has shown. And so eventually, knowing that in fact people are beginning to worry about publication bias, under publication, particularly with Ben Goldacre's recently published book called Bad Pharma. It's not just pharma, by the way, it's academia as well. I wanted to concentrate on this question, the need for reports of new research, to begin with up-to-date analyses of what's known already. Now, in some senses, the father of certainly trial medical statistics in our country is a man called Austin Bradford Hill, whom I knew, and he was a very, very nice person. Most people who came across him have only good things to say about him. And he was asked at a meeting in 1965 to comment on reporting of research. And there's a little note published in the BMJ reporting this summary of his position. Readers want answers to 4 questions. Why did you start? What did you do? What answer did you get? And what does it mean anyway? Now, Equator has been, I think, very, very important in addressing those 2 middle questions. Not so good on addressing the first and the fourth question. I'm going to concentrate on the first question. And this is part of a problem which Paul Glasziou, which is here, and I, in a paper in The Lancet in 2009, got published, and we reckoned that 85% of an enormous investment of, in essence, public funds in medical research was being wasted. And this article has caused a couple of, I think, good things. First of all, the National Institute for Health Research in the UK is actually monitoring all of its processes now for both commissioning and managing the research that it funds. But in addition to that, 4 articles have been commissioned in a series on waste in research, which will come out in the Lancet early next year. There are about 50 authors altogether. I'm a lead author on the first paper, John Ioannidis on the second paper, which is about the quality of research, Anwen Chan on the third paper, which is about underreporting, and Paul Glazou on the quality of reports at the end of the day. But going back to the item that's in red there, over 50% of studies are designed without reference to systematic reviews of existing evidence. It is an extraordinary state of affairs. Way back in 1996, 3 of us wrote a paper in which we suggested that research ethics committees were behaving unethically themselves. And one of the ways in which they were behaving unethically was by endorsing new research which is unnecessary. And we gave examples of the way that placebo-controlled trials continued to be approved really long after there was good evidence that giving an active treatment was useful. That ethical position was reinforced in a document in 2001 by our Department of Health, which said it's essential that existing sources of evidence, especially systematic reviews, are considered carefully prior to undertaking research. Research which duplicates other work unnecessarily or which is not of sufficient quality to contribute something useful to existing knowledge is in itself unethical. People have suffered and died unnecessarily because existing research has not been reviewed systematically. When I showed my draft slides yesterday morning to Paul, he said, "You've got an awful lot of stuff in that which you've shown before, cut it out and then put in this bit which I want you to talk about." So I did yesterday morning. So if it seems a little bit disjointed, I'm only giving you one result of this. And this is something which some of you may know about. Monoclonal antibody called TGN-1412 was given to 6 volunteers all at the same time, and they had dreadful cytokine storms and reactions. Some of them lost fingers and toes. Probably the immunocompetence of all of them has been affected lifelong. And the sad thing about it, as shown in this paper by Kenter and Cohen, 2 Dutch researchers, was that data were available which could have led them to predict that this would happen. So these people suffered unnecessarily. They all needed intensive care. Now, the other thing, of course, is that not only have patients suffered and died unnecessarily, but resources for healthcare and health research have been wasted. Way back in 1993, Lucy Carpenter, who's a medical statistician working in Oxford, pointed out in a Lancet article that good systematic reviews provide a valuable foundation for new research initiatives. So let's take this particular thing. Does the calcium antagonist nimodipine have useful results in animal experimental models of acute ischemic stroke? And as you'll see, the results of their systematic review didn't show any convincing evidence to substantiate the decision to perform trials with nimodipine in large numbers of patients. And indeed, 7,500 patients had been involved, had participated in controlled trials of nimodipine. In fact, they did the Cochrane review first and then said, well, because of this strong negative, what did the animal studies show? And that's when they did the systematic review of the animal studies. Now, I don't think anyone died as a consequence of this, but 7,500 patients in controlled trials don't come cheap. So waste of resources misled patients, misled clinicians also. They're not being adequately addressed, these problems. I've just given you 2 examples. I could have given you a load more. And indeed, in this series of papers on waste in the Lancet, beginning of next year, you'll have plenty of examples, both from preclinical research, clinical research, and epidemiological research. So here we have a situation where Karen Robinson and Steve Goodman, whom you heard speak earlier on today, produced what I think is an incredibly important bit of evidence, and must have taken an awful lot of effort. Basically, they used meta-analyses to identify reports of randomized trials published over 4 decades, and found that fewer than 25% of the preceding trials had been cited in the, as it were, the next trial. And obviously the implications of that is that there were ethically unjustifiable trials, wasted resources, incorrect conclusions, unnecessary risks for trial participants. And in another study, Nicola Cooper, David Jones, and Alex Sutton from Leicester, they've actually got in touch with authors of trial reports and asked them whether they had looked at the systematic reviews which are available before embarking on their studies. And in general, they weren't even aware that there were systematic reviews of existing studies. Now, Hilde Bastian, who used to work in this country at ICVIG, now works in NLM in Bethesda, and Paul Glasio and myself published this paper in PLOS Medicine not all that long ago, and said, how are we going to cope with this avalanche of not just new trials, but systematic reviews as well? There are a lot of systematic reviews now. As you can see, the contribution of the Cochrane collaboration to systematic reviews is pretty minimal. I think it's something less than 20% of the systematic reviews that are being published. So there are systematic reviews, and they are increasingly common. And there are 2 new resources, which maybe all of you know about, that I think will help the Equator Network to help others to address the serious problems in the earlier slides. One is PubMed Health, which is a new gateway to allow you to search specifically for reports of systematic reviews. And Hilde Bastian is the person who's leading on the development of that. And as you'll see, ICVIG, for example, is one of the organizations that's contributing to it. It's a very nice example of the United States reaching out to other parts of the world to say, look, let's try and crack this together. And we owe America, I think I owe the American taxpayers a great debt for actually investing in this. The other thing, and this we can say thank you to the British taxpayer, of which I'm one, is the register called Prospero, which is of ongoing systematic reviews. So you can find out what's in the pipeline already. And that's going to be important too, to help people tackle this problem. But there is a problem of continuing academic opposition from very high levels. I know that Gert will confirm that that's not an overstatement as far as Germany is concerned. So we've got this, for example, the Wellcome Trust, I think the third wealthiest medical research charity in the world, that says that it will not consider applications to support systematic reviews of clinical trials. I can't find it on its website now, but that was clipped from its website when it was on it. And I ask you, in the light of what I just said, whether that policy could be defended on scientific, ethical, or economic grounds. I don't think it can be. I got very, very angry and started to write a letter, which I toned down a bit. You know, you put it on one side for overnight and see whether... But I ended up by saying, basically, why don't these people who are taking these decisions about systematic reviews come out from behind their closed doors and have a scientific debate about these matters? I think they are intellectual cowards. Now, Sir Mark Walpert is currently the director of the Wellcome Trust. He's about to become the government chief scientific advisor next April. I went to see him soon after he was appointed to this post, and I said, look, even if you don't want to fund systematic reviews of clinical trials, what about promoting systematic reviews of animal studies? That would be a really good thing to do because people aren't doing it, it needs to be done, or even of methodological studies. No. Paul Garner, who some of you will know, he's the editor of the Infectious Diseases Group, went to see him 2 weeks ago, find out whether he'd changed his mind. No, he hasn't changed his mind. He says he's all in favour of rigorous reviews without actually being prepared to define what that means. But no, he's not going to change his mind about his opposition, his determined opposition to systematic reviews, where you have a protocol and you try to respect scientific principles. Well, the world moved on, even if Wellcome hasn't done. Here in 2005, there's a report from the Nuffield Council on Bioethics about the ethics of research involving animals, pointing out there's a relative scarcity of systematic reviews. And some people have responded to this. Malcolm McLeod is one of my heroes. He's a neurologist who does animal studies and human studies. And he's set up CAMARADS, the collaborative approach to meta-analysis and review of animal data from experimental studies. And that group and the people working with them from other parts of the world are doing a really great job. And in fact, there's a professor in Berlin who has been an animal researcher who's been extremely supportive of these developments. But if you try and get, in my country, the institutions of medicine to take this matter seriously, to discuss it scientifically, you get nowhere. This wasn't me writing to the Academy of Medical Sciences. It was a neurologist called Richard Hughes who said, can't we have a meeting about this to discuss the pros and cons of the methods that are being used? Never got any response. I was asked if I would chair a research strategy committee for the Multiple Sclerosis Society. And I thought about it for a bit. I don't know anything about multiple sclerosis. I said there were 4 conditions, and if those could be met, I would do it. The first condition was I wanted a lay co-chair, someone who knew multiple sclerosis from first or second hand. In fact, it was a relative. That was agreed. I wanted transparency about conflicting interests. I got that. I wanted a commitment that people would publish research that had been funded. And I wanted a confirmation that systematic reviews would be done before new research was published. The reason for that latter was I'd been asked by the MRC to chair a trial steering committee for quinacrine for Creutzfeldt-Jakob disease. And I said on 2 conditions, that I have a lay co-chair and that there is a systematic review to find out how we should design the trial. Well, in fact, the systematic review eventually got done. It was too late. We'd actually done the wrong trial. We'd looked at the wrong agent, not the one that was looking most promising from the systematic review. So that can waste an awful lot of money. When I chaired my first meeting of this Multiple Sclerosis Society effort, I said, I just want to check that the 4 conditions that I had indicated in advance were the conditions of me joining are acceptable. This man blew a gasket. You know, that's a bit of the car engine that keeps the steam in or whatever it is, I don't know. But anyway, he was very, very angry indeed. He went puce. And it was interesting that he had been a deputy chair of the governors of the Wellcome Trust. And in fact, I know that he's one of 2 people who've opposed Wellcome Trust involvement in systematic reviews of any kind. And he resigned from the committee on the basis of what I had required. What was nice, though, is that the other members of the committee, which included several patients, thought that it was probably a rather rational thing to do, like the people in the Munster bloods. And so we got it past the board, and what was nice was a systematic review of drugs in an animal model of MS was done of about 20 different drugs, 3 of which look quite promising. They have now led to human trials, which have been funded by the National Institute for Health Research, but through a program managed by the MRC, which is very nice that the National Institute for Health Research, which is about humans in general, have funded this. Why? These drugs are out of patent. No industry is going to be in the least bit interested in them, and industry's friends in academia are not going to be interested in them. They're interested in things that make money or have the potential for making money. So how can we expect patients and the public to trust that we've got their interests at heart if we in our professional institutions continue to acquiesce in such massive waste of the very substantial resources that they, the public, make available for medical research? Well, I don't think we can. I don't think that the research community is going to mend itself. I think the public needs to be made angry about this because they pay for the research. One way or the other, they pay for it. This book was written in a first edition in 2006 and translated into German and 5 other languages at that time. It was published again as a second edition last year. And here's what we said in the things that we wanted patients to see that they could do, which is to promote research addressing inadequately answered questions about the effects of treatments which you regard as important, and agree to participate only on condition that the study protocol has been registered and made publicly available, that the protocol refers to systematic reviews of existing evidence showing that the trial is justified, and that you receive a written assurance that the full study results will be published. The text of the book is being made in an interactive website at the moment. We've had very encouraging support from PAHO. Ludovic mentioned the things that he knows about, and he probably knows about this because Luis Gabriel Cuervo and Eliana Villanueva have been very supportive. The book's been translated into Spanish and Portuguese already. And lo and behold, Get Antes is going to be responsible for the sibling website of Testing Treatments Interactive in German. Finally, however, we need to be more efficient in preparing and updating systematic reviews. So in that same article to which I made reference earlier on, Hilda and Paul and I talked about the need to streamline and innovate in methods of systematic reviews. Here are the steps in a systematic review. How can we make it easier and faster to do these things? The challenge is, as pointed out by these authors, to make rapid reviews possible in ways that reduce the potential for introducing bias. So, if you have any ideas for these, please can you send them to Paul Glasziou. In spite of the fact that he has a U at the end of his name, his institution doesn't allow him to use his full name. So note it's pglazio@bond.edu.au. Thank you very much indeed.